The first case, the case number 9 from the speaker from Hong Kong, Dr. Chui Ka Lung, a case of cardiac arrest during rotablation, please.
Thank you, Chairman, for your kind introduction. So I'm Dr. Chui Ka Lung from Hong Kong. So I'm going to share with you a case of cardiac arrest during rotablation. So I have nothing to disclose. So my patient is a 65 years old chronic smoker, type 2 diabetes, hypertension, history of inferior MI 10 years ago with PCI to RCA and also PDA. And there is a mid-LAD CTO. And the echo 10 years ago already, the ejection fraction is 35 with some anterior hypokinesia. And actually, this is 1 month after the PCI to the RCA, and the RCA did improve. And we did a cardiac MRI, which showed a viable LAD and RCA territory, but there's a full thickness infarct in the circumflex. But at this time, this patient refused the LAD CTO and continued on only the medical therapy. So he was admitted a year ago for an NSTEMI with acute pulmonary edema, and the repeated echo show a ejection fraction of only 28%, and the LAD territory is akinetic, and the RCA territory is hypokinetic. And the coronary angiogram show is left main is 50%, LAD 90 calcified mid-LAD CTO as the angiogram in 2014. Circumflex is non-dominant, and RCA show a mid-RCA subtotal occlusion, proximal RCA 90% stenosis. Here come with the angiogram. So this is the spider view. You can see already the some retrograde feeding to the RCA. And the LAD is, proximal LAD is calcifying, mid-LAD is CTO. And the circumflex is non-dominant. And small views on the LAD, and you can see the RCA is dominant, is retrogradely filled by the left system. So this is the RCA angiogram. Basically, it's a subtotal occlusion at the RCA distal to the stent. And there's also another lesion, proximal RCA, that is proximal to the RCA stent. So we managed to wire, do some of the ballooning. And this is the angiogram after the balloon. And because there's no stent before and after the stent with stenosis, so we decided to put in a short DES proximal and another short DES in the mid-RCA, and we DCB the middle part of the RCA stent. And this is the final angiogram. So at that point of time, because it is a NSTEMI, although this is nearly subtotal occlusion, we found the LAD CTO because this patient initially refused, and we asked the patient on table. Patient is very keen, and he's not willing to come back for another stage procedure. So that's why, because of this very smooth procedure in the RCA, we decided to proceed to the same section PCI to LAD CTO. And you can see the retrograde filling to the LAD. So we set up a bilateral angiogram, and we use the femoral axis, and this is the EBU 375 guiding. And initially we used the XTA, but doesn't have adequate penetration power, so we changed to Gladius EX, but this cannot penetrate the distal cap, and we upgrade to a Gaia next third. We puncture the distal cap, and because of the distal disease is very severe, we step down to a filter XTA. We managed to cross the CTO with the XTA, and then we confirm with a bilateral angiogram, make sure we are in the LAD true lumen, and we are. And then we try to advance further my wire, and we try to then put the microcatheter, but the microcatheter is basically stuck at the mid-LAD. You see the heavily calcified mid-LAD part here. We use the 1.10 and also the 0.85 balloon, it doesn't cross. And finally, we have to jam our microcatheter here, and this is the rotor drive wire. We try to, this rotor drive wire is a new version of the rotor wire that has better maneuverability. So you can see a very good torque control. And after putting the microcatheter as far as could, and then we replace it with a rotor wire. the rotor drive wire. And then what had happened here, I'm going to explain in the next slides. So I think rotablation, the second operator is more important than the first one. So what has happened is you see there's two guiding here. So one is the EBU35. Because the second operator is not holding the guide wire properly, so it's actually the guiding is pushed out and got dislodged into the ascending aorta. So luckily, I don't have the wire in the LED, but this is a CTO that I spent some time in wiring. I don't want to lose my wire position. So I got a JL, the visual grade guiding has completed its role already. So I changed it out to a JL4 guiding. So wire down to the LED, and then I put a 4O balloon to anchor the rotor wire in the left main. And then I pull the wire at the same time, push in the guiding so as to re-engage my guide into the left main. This is the rotor, the EBU375 guiding from the right radial. So this is one time that I got a guiding actually dislodged into the ascending. This is the way I rescue this situation. Luckily, I have two access. So I think, this is a CTO, and I cannot pass a balloon, I cannot pass microcatheters. Basically, it's uncrossable lesion. So we do the rotablation. But mind you that this patient had ejection fraction of only 28. So we thought this is a CTO, and probably doesn't matter if we do something bad, and that's why we decided actually to go for a rotablation. So this is a one fiber, it doesn't cross, and then we step down to 120 fiber. And so what happened here? So after rotor for two run, so the blood pressure dropped to systolic only 40 to 50. So the first thing to do is to disengage the guiding, because sometimes your guide is jammed into the left main, and you got pressure damping. And also back your rotor burr, because sometimes the burr is obstructing the flow, causing the low blood pressure and also patient crash. And it doesn't work. And then we gave some intracoronary adrenaline, 10 microgram. It's a low dose. So we usually 1 to 10,000 adrenaline. We aspirate 1 ml and dilute 10, and then give 1 cc to the patient by intracoronary. This helped to boost the blood pressure immediately. But after 4 or 5 bonus, the patient doesn't have a response. And then went into cardiac arrest very quickly. So in my center, putting in a ECMO may usually take 45, 60 minutes. And impeller is usually very fast. Our cath lab is very efficient in putting impeller. Is in 5 to 10 minutes, we already get the access already. So we change out to the impeller sheath, and then within 5 to 10 minutes, we have the impeller in place. And after actually a brief CPR and also boluses of IV adrenaline and also some IV noradrenaline, patient blood pressure came back. And then we put in the impeller to support our further procedures. So this is the check angiogram, because we also puffed before, and we found that actually basically there's no reflow phenomenon, and you don't see any flow down the LED. That's why the patient is crashing. And maybe we put in the impeller, we continue our work. We luckily, during the CPR, we don't lose our wire position. And then we continue to use the 125 burr to complete the task. So this is the 125 burr. We managed to pass through the tight lesion in the mid. So usually if the microcatheter don't cause a 125 burr would be a better choice. So after more runs, we can manage to pass beyond that tight lesion here. Yes, like this. And then we did a few polishing one. And then we put into long drug-eluting stent, do the provisional stenting with wire protection to the circumflex. And then this is the final angiogram. Okay. So learning point in this case is, complete revascularization should be the goal in most patients in multivessel coronary artery disease. And however, the best timing for the stage procedure should be individualized. In some patients with poor EF, complex CTO, and anticipated, although I don't anticipate use of rotor in this case, but if there's any anticipated need for rotablation after treating the culprit vessels, it's more wise to consider a stage procedures. After the patient rests for some time, a course of medical therapy, the EF may improve, and that may be a better choice in this case. And of course, you may consider upfront use of MCS, but it's sometimes quite difficult to predict which patient is going to need it. And also the cost of MCS would be a big consideration in most of the center. And also, in this case, sometimes play-out use of MCS, be it ECMO or impeller, can be life-saving. It depends on your center expertise. And some center is very expertise in using ECMO and can implant an ECMO in a very short period of time. The nurses are very equipped, well-trained. So ECMO may be a better choice, some center. And in some center, if resources is okay, and impeller actually is more physiological and support the heart. Although it's not a complete support to the heart, it cannot support the right heart, it cannot support the lung, and it's not a full support to the LV. So it has to be individualized. But play-out use of MCS can be life-saving in situations like this. So thank you very much for your kind attention.
Thank you very much. We have more than 3 minutes left, so maybe we ask a question. Yeah. How do you think about this case? I want to ask Dr. again, Brian Wu.
So I think the case is very nice. You managed to rescue a very difficult situation. Would you have considered upfront impeller in this case? Because the right was very tight and obviously a culprit vessel and you affected it. And obviously you don't want to stage the patient because last time he refused his PCI to his LAD. So maybe after doing the right would be a time you could consider using impeller upfront?
Yes, but in Hong Kong, we need to apply a special funding. So that means the patient have to come off the table and see the medical social worker and seek the approval before you can use it. Or if the patient is shocked, you can use it immediately. But if the patient has a stage procedures, and he needs to apply a funding beforehand. So that's because the patient strongly refused to come back, and we are somewhat like forced to do. But I myself think that in next case, perhaps, even though the patient requests, we may not entertain. In safety always come first before anything.
So when we do the very severe case, very difficult case, we have to have many devices to support our procedure. Thank you very much.
Thank you very much.
We go to the case number 10 from Dr. Phan Tuan Dak, Trawl gone wrong.
So good afternoon, ladies and gentlemen, and I just want to thank you, organizing committee of the SIF, to giving me a chance to present the case. The Trawl is gone wrong. It is a filter entrapment case, so I don't have any conflict of interest. So let me introduce. It's a 66-year-old male patient with a history of the significant cardiac risk factor, including the hypertension, diabetes, and dyslipidemias. And nearly 40 years ago, the patient underwent the coronary artery bypass grafting with 2 grafts, Lima to LAD and SVG to RCA. And for the past 2 months, he had experienced the exertional chest pain, and his echo revealed that the preserved ejection fraction, creatinine, his renal function, and troponin were reassuming and both within the normal limits. And coronary angiogram review the critical, the 90% the stenosis at the proximal LAD, as you can see on your left-hand side. And fortunately, the Lima and LAD graft remain widely patent, ensuring the good flow to the anterior circulations. So moving to the right coronary, that we cannot engage selectively because you assume the RCA was occluded as reviewed in the autogram on the right-hand video, as you can see. And turning our attention to the SPG to the RCA, we identified that the complex lesion with the 90% of stenosis of the distal anastomosis and the 70% of the mid LED to the graft. And you can see that interestingly that the graft is very short, reflecting the surgical technique that almost 4 decades ago. And in terms of the patient symptomatic presentation, and we decided to do the PCI to the SPG to RCA graft. So due to very tight lesion at the anastomosis, the distal protection device may not cross. So we decided to pre-dilate with the 2.0 by 15 mm balloon to pre-dilatation the lesion first. And once the dilatation was achieved, we successfully crossed the lesion with the spider FX 3.0 mm filter device and put it in the distal RCA under the fluoroscopic guidance, as you can see on the slide. And moving on, as we quite easily to deploy the stand at the mid RCA with the stand DS 2.5 by the 24 millimeters. And because we think that it is quite a separate lesion, and we decided to use the spot 10, and we deploy another stand. The stand here is for the anastomosis. We choose the size of stand 3.0 by the 14 mm to deploy to the SPG, SPG lesion here. And we post-dilatation with 2.5 by 10 mm and T-balloon, and as you can see that we can achieve the excellent angiographic results. And at this point, we are ready to retrieve the filter device and conclude the procedures. But then the unexpected happened. And while we are attempting to retrieve the spider filters, we encountered resistance here. The retrieval catheter, you can see that cannot cross the HVG stand because I think that the stand is not full expansion after the post-dilatation. And because of that, we tried to pull back the spider's device, but it's come trapped within the stand, the distal stand. So this leads to the deformation with the distal portion, the stand compressed and shorten the stand at the mid RCA. So we think that we have to illustrate what is the mechanisms has been proposed to call the filter entrapment on my case. So I can have the two mechanisms have been proposed here. The first one, when we retrieve the catheter enable to cross the SVD stand leading to the failure in the filter retrieval, I think that the first stand, because the stand is not full expansion after the post-dilatation, and I think that the catheter is not coaxial within the stand. That's why that the catheter retriever cannot cross the SVD stand on that case. And secondly, that we think that when we try to put back the spider entrap into the distal end of the stand and deform the stand with the stand, and you can see that the stand vertically compressed and shortened and make the stand deformation. So this is a nightmare. So what in this situation, what would you do the next step? The first one, you transfer the patient for the surgery, or you attempt to pull the filter out with the greater force, or you find an alternative method to retrieve the filter through the catheters. And I just want to ask you, who's going to be choose the answer A? Nobody, right? Answer B, you want to greater force. Yeah, anything that we all agree that we should choose the answer C, because we know that if you change the patient in surgery, it's very invasive, and all Vietnamese patients prefer the less traumatic options. And for the answer B, I think that is absolutely contraindication, because all the filter stuck into the mid of the RCA stand. If you try to use the greater force, you can make the worse the stand deformation, and you make the filter retrieval more challenging, and you can lead to very dimensional complication on that case. Also, I try to retrieve the stent by using the catheters. And the first one, we cone to the surgery to back up on the standby while we try to retrieve on the triple wire was attempt. On that case, we use the second wire were inserted into the attempt to place the body wire beside the triple filters. And that's one year we have more room, and I think that on my case, I'm quite fortunately because the spider filter has not been tightly stuck into the stent, so it's allowed me to use the 3.0 mm balloon and to put it in, and it's allowed me to move further distally the spider when the balloon go advance. So you have more room to retrieve the filters. So on that case, on the next step, we use another one that use a guide liner were brought to the proximal edge of the mid RCA deform the stent, and we use the small balloon, the wise manner using the 1.0. We upgrade to 2.0 and 3.0 balloon to dilate the deform the stent. On that case, you can see that we start with the 1.0 mm balloon followed by 2 mm balloon, and finally that we use a 3.0 mm balloon. And that's one, and finally that we can use a 3 mm balloon, and this one we successfully restore the stent shape. And with the guide liner now, you can see that we can able to pass through the stent, and we can capture the spider device and retrieve the device out. And you can see on the slide. I think that the step here, it's very important that you can use the guide liner to touch the filter, and you successfully retrieve the device out. And this is the post removal. And you can see that after we post the removal the spider out, and now you have time to fix your mistake. So after you put in and out all the devices, you make some traumas in your coronary. So we rewire the ICA and we deploy a stent 3.0 by the 38 mm from the distal HVG scrap to the mid RCA. You don't want to make any trauma here. And the final angiogram to confirm that silent flow with no residual stenosis is the satisfying to end the challenging case like that. And this is a final angiographic result, the good flow and no residual stenosis noted. So this is a nightmare case, and it brings me to the conclusion of my presentation. And the future entrapment with the stent can have the serious consequences. And it's very important, crucial, to ensure that the filter device is partly retrieval into the catheter before attempting with the withdrawal. And if you feel any resistant encounters, you have to pause, carefully assessment and should be performed to identify what is the cause, what is the underlying cause, and rather than forcing the greater force to the device. And using guide liner on my case, advance over the balloon, inflated balloon is a useful option to retrieve interrupted filters. So in a beautiful day, you want to go fishing and you want to trawl fish, but sometimes you cannot trawl fish, you catch turtles. So in my case, the turtles cannot himself to go in or go out the fishing net. So if you understand the under cause, you have to pause your procedure first. You have time to understand what is the cause of the entrapment case or like that. Or for my case also, I won't foxing or rushing, I may harm my turtles. So I will use my technique to cut the net at the suitable position. So I finally can rescue my turtles. Thank you for your attention.
Thank you very much, Dr. Phan. So we have one or two questions from our panelists to the speaker. I would like to invite Dr. Lam Ho.
Excellent presentation. Congratulations. You settled a very malignant complication. So in this case, about prevention, if you can do it again, if the time can come back, if you do it again, what will you do so that you can prevent this complication?
Thank you, Dr. Ho Lam, for your interesting question. I think that if I have chance to redo the case, I think that I will pause at the step I cannot engage the retrieval catheters through the SVD stent first. Because I think that the stent is not full expansion after the post-dilatation, I will use the maybe bigger balloon, your 2.0 by or 2.25 mm balloon to pre-dilatation, especially for the ostium of the standard SVG first. This is very important because you cannot coaxial. And after that, I can use the smaller balloon inside the retriever catheters to make the catheter the coaxial. When the catheter retriever can partly retrieval of the spider's device, I will remove it down. Yeah.
Hi, I'm Asri. Very good case. I think one of the issues is this is a very unusual graph. I've never seen such a short graph going to the side of the RCA.
Yes.
And most of the time when you use this easy filter retrieval devices and so on, they're meant for straight, graphs and so on, not take such angles. So I might not even have used the retrieval because of worry, because when you actually pull back, you pull back over an angle, very unusual angle to come down. Just a comment, So, and there's a possibility for the device to get stuck.
Yeah, I think I'm agree with you because the graph was done 40 years ago when the technique cannot go to the distal part of the RCA, so the graph is quite short. So on that kind, I agree with you that the angulation is quite acute, and if you have a chance, you can deploy the stent. Yeah, it's not a spot stent like my case. You can deploy the stent from HPG to the mid RCA, so you can avoid the very acute angles.
Okay. Eric has some point to.
First, record account.
Oh, it's not a question. Just to share a stupid thing I did. Complication. So if you sometimes if we use the filter device for critical vein graft, and it's very difficult to pass, and sometimes I use a buddy wire, and then mostly I use the Boston filter. And what happened to me once, I didn't pull the buddy wire and I stented on the wrong wire. So that means that you jail the filter. Has anybody had this complication before? It's stupid, huh? Of course. So what I did, I just pulled the filter out and I crushed the stent. I just recrossed the stent and nothing happened.
Thank you. I just give a very short comment. On top of adequate % high pressure on the stent, another way to avoid this complication is early use of guide extension. Particularly, you can use guide pass. And then don't use the bull catheter provided by the spider X. It's very difficult to retrieve the filter wire. You just use guide pass and then go down and then take it out before it enters the stent. So there's one important.
Thank you. Thank you for your comment.
To me, I want to avoid this problem because this is a maybe a complex lesion. So we need to do IVERT or OCT first. If not thrombus very much in the vessel, we don't need to use protection device. And if we don't use it, we don't have this problem. Thank you very much.
Thank you.
And I think to your point about using the guide extension for extraction, if you also load like a bad technique, put a 2 millimeter balloon in front, just so that you can help it get past any protruding stent parts, that also really helps. It's much better than the retrieval device that comes with the spider filter. Much better.
Very, very important. Because of time, I did not explain is because the filter wire actually will make your wire bias to the wall of the vessel. So you put one balloon or you inflate one balloon to centralize the wire, then it will be more easy for you to pull it out.
Yes.
Thank you very much for your comment. We go to the next speaker. I would like to invite Dr. Hoang Vu from UMC with the topic tips and tricks to manage the complication in complex rotational atherectomy.
So thank you, Chairman. So I know that all of you from Hong Kong and all the colleagues here, you are the expert on the rotablation. So today I just talk about some tips and tricks for rotablation atherectomy. So the first one, the indication of rotablation. This is the definite indication on so possible indication in daily practice. In our center, we usually use the IVERS for almost 100% of the case. So it belong to the IVERS finding. And also, if the IVERS and device cannot cross the region, we can use the rotablation for the patient. And how about the penetration of the rotablation in the Europe country is in the table show you that it's about highest one in United Kingdom, about 3.1%. We don't know about the Hong Kong might be higher than this. And how about in our country, maybe around just about 2 or 3% of the case. And how about the clinical outcome? In hospital clinical outcome after rotational atherectomy, this is the registry from the Japan, over 13,000 patient rotablation. So with the composite outcome is about 1.3%, including in hospital death, cardiac tamponade, and also the emergent surgery. So they didn't count the complications, for example, the arrhythmia or slow flow or something like that. They just count about the in-hospital death and also cardiac tamponade and also the emergent surgery. And how about the risk factor for the complication? So in this analytic, they show that the experience of the doctor is one risk factor, and also the age of the patient is a risk factor also, and also the ACS setting is also the risk factor for the complication. And this is our center. So far we have over 223 patients with rotablation in 5 years. So the IVUS penetration 93.6% in our center, and triple vessel disease about 75% in our center. And now how about the successful rate in the rotablation in our center is 96%, and the slow flow 4%, vessel perforation about 2.2%, and mortality 2.7%, and total MACE in hospital is about 8.5%. And this is our experience about the rotablation. 93% rotablation, we use IVUS guided rotablation, and also we use the dynacline mode to bring the burr to the lesion. And also we use only the burr 1.25 to 20 mm burr only. And for the small burr, we have a speed about 180 RPM to 200,000 RPM. For the bigger burr, about 160,000 RPM for the patient. And how about the complication? We know that the slow flow, coronary dissection, also coronary perforation, burn entrapment is a common complication of the rotablation. So how to prevent it? A slow flow, we use small burr, lower speed, and maybe in our center, if the blood pressure before the procedure is under 120, maybe we use a noradrenaline to keep the blood pressure before we do the rotablation. Also, we use the atropine frequently before the rotablation. And coronary dissection, we have to careful case selection to avoid vessel tortures. And also, we have to see about the IVUS finding by why bias during the IVUS finding to see the risk of the coronary dissection, also the perforation. So that's sometimes we have in our center we have over 200 cases, and we have 2 cases with burn entrapment. So we have to use a second wire to facilitate the wire withdrawal during the procedure. And this is some tip and trick to prevent and allow the slow flow. How to prevent the slow flow? We have to use appropriate spur size, for example, 0.5 or 0.6 compared to the vessel size. If we have the IVUS, we can up to the 0.25 to the minimum vessel diameter, lumen diameter. Also the short ablation times, and avoid excessive speed down to prevent the slow flow, and keep the systolic blood pressure over 120 mm mercury, and use noradrenaline to keep the blood pressure also. And sometimes we use IBBP if the person have slow flow or the person have a low ejection fraction. And how about how to prevent the coronary perforation rupture? So I think the most important is that we use the intravascular imaging to guide the rotablation atherectomy procedure to reduce the risk of the perforation in the patient. And this is the picture, show you the risk of the circumflex ostium perforation. Two mechanism of this. The first one, you see the upper picture. If the calcify in the left, in the right hand side, if we use maybe the rota wire, the floppy wire, maybe sometimes it can make the rupture. In this case, sometimes we have to use the extra support wire to keep it. And the second picture in the lower is a second mechanism of the perforation during the rotablation for the circumflex. And this is the literature review about the burr entrapment, how to deal with this. So you see in the pictures, most of case we have to use the second wire. We have to use the second wire to resolve the problem, and we have to use a surgical removal for the patient. And sometimes we have the modern child, we have a deep intubation with the manual pull back or something like that. But most of case we have a second wire, and maybe the balloon can reduce, can resolve the problem. And this is the algorithm for the burr entrapment. So we use a second wire is the first step. If not, we can use if we cannot withdraw the burrs, we use a balloon. And if we cannot, we can intubate it deeply and remove the burr with the catheter. If we cannot remove the burr with all the solution, we have to cone for the surgery. And this is the halfway rota, the schema for the conventional and halfway rota. This is the way that we can do in some complex case to reduce the risk of the perforation in rotablation atherectomy. And this is the case I show you, the left main LVD severe calcification. We have left main disease, distal left main disease, very heavy calcification from the left main extended into the LVD to the mid LVD, very heavy calcification, and TB flow only 1 or 2. And we use a 7 French guide catheter, and with the radial approach. This is the field XTR cross lesion, but in the right hand side, we can in the right hand side you see that the microcatheter cannot cross the lesion, so we have to use move the microcatheter into the distal, very distal, as fast as possible, and we use a rota wire to cross the lesion. And this is the 1.25 burr with 180 RPM. The first step, we just rotate in the proximal LED, only the proximal. Keep it proximal first. And when the burr is very easy to pass the proximal LED calcification, we go to the next step, go to the middle of the LED rotablation. And as you see in the right hand side, the burr go to the middle of the LED. And you can see in this picture the burr entrapment in the this is the rotablation, and in the right hand side the burr entrapment in the LED. So I cannot move the burr outside. Yeah. So what we do next? What I do? So we insert a second wire into the same guiding catheter because the flow is okay, the hemodynamic is okay. So we just put the Xeon wire, go to the burr and rotate it a lot of time, rotation of the second wire. And in the right hand side, you can see the burr can move out with the dynamic glide mode after we insert the second wire into the LED after burr entrapment into the LED. And after that, we rewire again, and you see that the rota wire is here, the first rota Y here, and the second rota Y. We have to put it in again, and we do rota again. But at the beginning, we go with the speed about 180,000 RPM, but the bird couldn't cross the region. So after that, we have to increase the speed about 20,000 RPM, and after that, the bird crossed the region. So this is the before and after PCI. You see the left-hand side, we have the very long lesion, heavy calcification from the left main to the LED to the middle of the LED. And this right-hand side, we see the after stenting, the two stent, too long stent, the LED and left main is acceptable. So for conclusion, the rota complication is not so common, but it's quite dangerous for us. And the risk of severe complication after rotablation were four-fold higher than in emergency PCI compared to the elective PCI. And also the risk of severe complication were approximately a half in a high volume institution as compared to the low volume institution. Thank you for your attention.
Thank you, Dr. Vu. Yeah. So, any comment or question from the panelists?
Thank you for a very nice case. The rotor burr stuck, your second wire, you used to loosen the rotor burr and then you use Dynaglide. Is that right?
Yeah.
Oh. What if that doesn't work? What is your next step?
Yeah, so that is a very interesting question. If we cannot remove the burr, maybe we have to puncture another side femoral, and we use a wire and balloon to open the ping pong technique to open the proximal part and even the burr to take the burr out. And if cannot remove the burr, maybe we have to cut the burr, and we use mother and child to and deep intubation of the mother and child to remove the burr. So.
Hi, Dr. Wu. I'm very happy seeing your initial slides. So your protocol of doing your rotablation in your center is like exactly what I do in my center. I think what's interesting in one of the slides is most of the burrs which get stuck are the 1.25 burr. 1.25 millimeter burr is the one which gets stuck the most. 1.5 is much less. So people always think taking a smaller burr will help. No, because of the shape of the burr, 1.25 is the one that gets stuck. And here's interesting is like what you mentioned just now. It's very interesting. Just by twirling the wire, you manage to take out the burr. But most of the time, I need a balloon or whatever to balloon. And like what Professor was saying, Eugene, I think the other one is a mother and child. So you must be well versed where to cut, how to put in your guide extension right to the burr, and then try to pull out. Most of the time, it will work. Yeah. Just a comment.
Thank you. Oh, thank you, Dr. Vu. So we now to the third case of this section. I'd like to invite Dr. Szu Chi Chien with the topic PCI in young AMI with the multivessel thrombosis.
Okay. Hello, everyone. I'm Dr. Jian from Taiwan Zhonghua Christian Hospital. And thank you for inviting me to this wonderful meeting. And just gonna show my case. I have no disclosure. And this is a 33-year-old male with history of smoking for 10 years. And we can see he got a very high LDL. And BMI is around 34. His height is around 170 centimeter, and body weight is around 100 kilograms. And he started to feel chest pain since maybe 3 days before. But on that day to our hospital, he felt the chest tightness exaggerated. So he drove by himself to our hospital and was found falling down in the corridor of our hospital by other patients on the ER day. And he was sent to our ER with the present illness as dyspnea and slurred speech in ER. So we can see the ECG and X-ray. You can see the lead 2, 3 AVF, and V5, V6 ST elevation. But not that severe pulmonary edema, but because the dyspnea symptoms, he got intubated in the ER. Well, as in this ECG, maybe RCA or circumflex maybe. So we can check the RCA first. Okay, RCA is okay. So I think maybe circ. Okay, you can see that. Yes, you can see this circumflex maybe is the carpal lesion, right? But do you see others? You can see LAD. In the middle part of LAD, there's a filling defect. And others, you can see left main. Do you see that? In left main, there's a floating thrombosis. Okay, so how do we do it? I think basically on the ECG, the carpal lesion may be in the circumflex. So I think to do circumflex is the most important one. So I started to do the circumflex. I try to use the EBU guiding, try to engage well. Then the floating thrombus in the left main may not move out. So I started to do circumflex OM1. That's easy after using the advanced aspiration catheter, as you can see that. It's easy. There's no calcification in this young man. So after that, OM1 is okay. Then I go to do some thromboaspiration in OM2. It seems like okay. So I want to fix the LAD because I don't want to face the two front wall. So I do the LAD thromboaspiration. So there's, as you can see, there's still some filling defects. So I just do direct stenting in this LAD. So use the Onyx 3.5 millimeters, 30. So after that, you can see that LED is okay. So I can focus on the circumflex again. So back to circumflex, I do multiple aspiration and using the stem balloon to do low bar balloon dilatation. Then here's the I think this is the final angiogram. Of course, maybe you will do other things like just do direct stenting. Can I have your answers? Anyone want to do direct stenting in this time? Please raise your hand. Okay, no. And GPI and stage PCI, or maybe we can do some IVUS image. Anyone? Okay, or others, okay? So because the circumflex is quite large and still a lot of thrombus, so I use some GPI, then use the Clesen, so for several days. Then within these 3 days, we do some exam for this patient. Heart echo is okay, as you can see that. So my plan is to do circumflex using the KRX with Indigo system. It's a continuous negative pressure with 1 ATM suction. I think it's work for this patient and using OCT. So after GPI and Clesen, as you can see that circumflex got quite well, I think, but still thrombus. So I do OCT. This OCT still got some thrombus, so may not see that very clearly. So I use the KRX to do some thrombo aspiration again. And after that, as you can see, it's more clear. So I do the OCT again. So we can see that. Why is the this patient got STEMI? It's OM here. You can see that. I think it's plaque rupture here, just above the OM area. So as we can see that, we just do stenting using biofreedom 4.0 and post-dilatation with NC 5.0. Okay, that's good. So after that, I do OCT again to check the if the stent well. The stent well post-dilatation and apposition is good. So after the final post-dilatation, the flow is okay. So finished? Not yet. Do you remember the patient got slurred speech in the ER? So in that 3 days, we do some chest CT, heart CT, and brain CT for this patient. And we found other things, as you can see here. There's a thrombus in the iliac artery, left iliac artery. And besides, do you know what happened with this brain CT? ICA is okay. So you can check the vertebral artery. In the left vertebral artery, it's okay, right? But in right vertebral artery, it seems like occluded. But some of us, the vertebral artery get naturally diminished. So in the first CT report, they said it's just a small vertebral artery. But we do the brain MRI. So as you can see that in the DWI image, there's a hyper signal in the cerebellum area and low signal in ADC. So that means this cerebellar ischemia is acute. It's very acute. So by the MRI report, it's acute ischemia infarction in this cerebellar, including the pica area. So I want to use the aspiration system to do all the thrombus, try to move all the thrombus out. So the first is this left common iliac artery floating thrombus. I just use the indigo system to connect with the JR4 and do the thrombo aspiration. It's done. So after that, we can see it's quite clear. And we sucked out a lot of thrombus. You can see that. It's very clear. Then, after all, I try to do the right vertebral artery. So we can see that. Where's the vertebral artery? Can you see? Let's focus on here. You can see just right here, there's some flow, just here. Okay, maybe I'll show you with the laser point. You see here, something here, this. So I use the Sion wire with Caravelle microcatheter and try to negotiate this vertebral artery because I think because it's acute, so maybe I can find a way. Yeah, luckily I can go on. Then I use this Caravelle microcatheter, try to advance inside and try to do some aspiration. And then when I have aspirated the blood, I do some tip injection. So as you can see that in the very distal part, even the basilar artery is not involved by the thrombus. So I think the thrombus is only inside the vertebral artery, not involved into the basilar artery. So I started to use the CAT-RX and indigo system, try to do some thrombo aspiration with the vertebral artery, but it cannot be advanced. So I changed to connect with the export advance. Export advance can reach here. So I do some several times of aspiration. Then I do the tip injection. As you can see that it's quite still very large amount thrombus in the proximal vertebral artery. Then I do some pull back to check where's the thrombus. There's a huge thrombus here, as you can see that. So I think the tiny aspiration catheter cannot draw the whole thrombus out. So I just connect 5-branch ST01 with the suction system. And after that, you can see I draw all the thrombus out in some just in the subclavian artery here. So I check the flow. You can see that flow comes out, all comes out. And something we need to check is thrombus may dislodge to the radial artery or something. So I check. Yeah, the thrombus just dislodged in the bifurcation of radial artery and ulnar artery. You can see that here. But I think that's easier. So I just wire down and do thromboaspiration with ST01. Then final, as you can see that, all the radial artery comes out. I think some residual thrombus is inside the ulnar artery, but I think that's okay because palmar arch comes out. So the patient is in OPD follow-up, and it's okay. No any neurologic sequela. So I think apply this kind of indigo system for this coronary thrombus, iliac artery thrombus, and vertebral artery thrombus without any neurologic sequela. It's successful. And I think it's an interesting case with multiple thrombus, not only in the coronary, but also in others, like iliac artery and the vertebral system. And OCT confirmed the coronary rupture plaque in circumflex, but we still not know what's the etiology about the other side thrombus. And I think heart echo show normal, and we also do the bubble test, it's negative, so there's no intracardiac shunt. So my medications now is triple, DAPT, NOAC for 3 months. Then now I change to the DPI with Plavix to NOAC. So this is my case, and welcome to Taiwan for another meetings. Thank you, thank you.
Thank you, Dr. Szu Chi Chien. We have one comment from panelists. Invite Dr. Professor Hoàng Anh Tiến.
Yeah, so very interesting case, and you have results with the perfect results. And I have some comment that in very first times when the patient admitted to the emergency department, maybe we can use the EKG to find out with either curve bridge lesion. For example, in this case, we can see that the elevation of AT elevation is the D2, D3, and ABS, also with the V5, V6, and D1 and AVL. So it means that it should be the circumflex lesion. Or we can see the elevation, AT elevation in the D2 is higher than D3 or ABS. It's maybe the circumflex lesion.
Yes.
And the second is in here we follow up. It means we chase the shadow of the disease. So what you should check about, for example, ACT. We should use the anticoagulation. It's very strong. For example, maybe we use thrombolytic or some heparin or some inosartan, for example, to prevent the further thrombosis in all the arteries.
Yeah.
Yes, I think it's a very maybe important, and we can mention in the clinical. Yeah.
Yes, thank you.
Thank you very much. We can come back to this topic at the discussion part. Yeah, thank you.
Thank you.
And now, Dr. Võ Anh Minh from Tâm Đức Hospital in Ho Chi Minh City will go to the 4 cases of this section. Is coronary spasm benign or malignant?
So good afternoon, chairmen, panelists, and all colleagues. So I would like to share 2 cases today about the coronary spasm. So the first case is a 68 years old smoker male. He complained about the chest pain. And in 2020, he came to the local hospital with the non-STEMI scenario. And our college did the CAC, show the stenosis at the distal left main, and they also did the NTZ, so the coronary spasm, but still had a fifth stenosis, and they deployed the stent. 3 years later, he visited to the north of Vietnam and visit his hometown, and he have a recurrent chest pain. And the CAG at another hospital showed the RCA spasm and relief with the NTZ. But and they optimal medical treatment with the calcium channel blocker and nitrate. And but after that, he very upset and depression because due to he have admit the ER 4 times a month with the chest pain, with the recurrent chest pain, and the family very upset and called me and asked me to come to our hospital. After he landed the airport, he had a severe chest pain and came to the ER with the third AV block and the AT elevation at the DIS2, 3, and AVF. And my colleague, he gave him the sublingual NTZ, and the third AV block and AT elevation is gone. We also did the CAC, show normal, not significant. But I question why he have a recurrent chest pain with the coronary spasm, and according to the history, and I take the detail, the history, he have a snoring, tired in the morning, almost the situation he had occur in the early morning. And he hypertension, older age, male, and we take the stop bank, and it's a high risk for the ulcer. We take the PhD for him, and the severe obstructive sleep apnea with the is nearly 36, and I gave him the CPAP, and almost he totally respond with the CPAP and no recurrent coronary spasm or chest pain. And we look back about the literature about the ulcer as a beta for the vasospastic angina, and it's many report about that. So I move to the second case because today is a complication session. The second case is a 79 years old male. He came to hospital because the unstable angina, syncope, heart failure, and hypertension. We saw that he have a severe stenosis at the RCA, and we proceed to do the PCI for the RCA with 2 stents. And after stent, we saw he have a spasm at the proximal RCA. We did the IVUS, of course, with no dissection, and we give him the NTC and release. And I moved to the LAD stenosis. Look at the severe stenosis and torches at the mid LAD. So look at clearly about the stenosis here. Okay, look at it okay, but normally for the torches I use the Rendru white, but at the time I'm not able. So seal blue white will be okay, but a little bit underestimate the lesion. So after I wiring, so you see it's a mid LD will glue after the wiring. So at this time, of course, it's a dissection at the torches area, so very difficult situation. So we have no choice. We have to pass the occlusion. So I use the feudal HDR to try to cross the lesion. So let's look at the second view. So it's a true or false lumen. It's not easy to I check again if I advance the microcatheter, maybe the dissection more. And the third video we saw clearly, and you the workhorse Y, and slowly look at, I see the distal one, I think it's a true lumen, and then I check with the IVUS. So of course it's true lumen, some thrombus and dissections. At this time, I decide to deploy the stent for the patient with the 2.75, 48. But it's not just dissection, but still have the slow flow. But according to the IVERS, I decide to deploy the stent first and then see what's going on. So after deploy the stent and IVERS, we still have the no reflow. Some thrombus, minor dissection, and the distal S still acceptable. And but for the next one, we see, oh, it's not my it's not my days. Like, it's a perforation. I'm not sure, but I advance the balloon inflation first to see what's going on. I review the answer, and then I push the hydroadenosine, like the first choice of my cat lab about the slow flow and no reflow. But it's almost not improved well with the hydroadenosine. But this patient is much better with the NTZ for the slow flow and no reflow. The final one is look okay. He no chest band, the hemodynamic is okay, so I stop the case. But after the change to the post BCI work near to the cat lab to see what's going on, the first EKG and the second EKG. So of course I have to take the patient to the cat lab again to see what's going on. It's slow flow, but it still have improved with the NTZ. So then I waited a little bit and did redo the CAC. It's recurrent, no reflow, and slow flow. So I did the IVERS. So I think the patient have some dissection at the distal. So probably it's make the thrombus to emboli for the patient and make a spasm at the distal. So the IVERS shows some minor dissection at distal, so I deployed another stent to the distal. But after deploy the stent, it still have a slow flow. It's really trouble at that time. But you see, almost no response with the adenosine. But again, I confident like this patient will respond with the NTZ for the nitrate. So I with the hydro and hydro with the nitrate. It's good, get better very quick. And I plan to infusion the NTZ and the calcium channel blocker, enoxaparin, something like, and transfer to the CCU for the monitor for the patient. And the patient, he don't have any chest pain, and the vital sign is stable. And that is why I transfer him to the CCU. But at the CCU, you look at the EKG, still at elevation, but look, it's quite a little bit better at the EKG before I take him to the cat lab again. And then he suddenly lost consciousness and bradycardia, no pulse, cardiac arrest. We did the CPR, ACOS with the one impulse of the epinephrine. He was constant. Conscious after 5 minutes. The monitor show AT elevation is high and high frequency of the BVC and short VT. At this time, my colleagues asked me take him to the cat lab or not. I know if I take him to the cat lab, I do nothing. I don't know what should I do next. But we treat him with the amiodarone first because the high frequency BVC. But it's magic. After 5 minutes, 15 minutes, active elevation well resolved. No BVC, no recurrent short VT. The activation resolved well. So I read in the internet about the literature why this happened, and we keep to monitor him and follow up at the ward, and he improved well and discharged after follow up at the IBD. And the EVF is good, it's no change. It's my explanation is his coronary is inserted by the intimal media and can make the thrombus, can make the slow flow and no flow, but not all. And some chemical like the ET1 can make him the constriction, can make the microvascular spasm. And we see the literature, they show like amiodarone can acutely affect to arteriovascular endothelin converting enzyme. And I also searched some reports about the reviews about the coronary microvascular dysfunction. And amiodarone also had the potent coronary vascular dilatation. And we look back about the history in 60 years ago. Amiodarone was induced like an anti-angina in Europe for stable, unstable, and variant angina, and it can improve the CFR and prevent it for the coronary constriction. And they also had a study like intracoronary amiodarone confirm about the potent coronary vascular dilatation and can improve the flow. And when we see some case report in the internet, some patients have a repetitive variant angina attack could be controlled with the amiodarone. So it can combine with the conventional treatment in some case. So my conclusion is prognosis of coronary spasm generally is benign, but could be life-threatening in some situation. And we have to find in the trigger factor about the coronary spasm, like the obstructive sleep apnea or something. It's very important to treat the coronary spasm. And the final, in case of repetitive coronary spasm, we have to combine treatment with the multiple mechanism effect is necessary. Thank you very much.
Thank you, Dr. Anh Minh. Yeah, I just feel not very comfortable in my chest. Give me some amiodarone. Huh? Yeah. I want to hear some comment from audiences. Dr. Phan Tung Dak, what you are feeling in this case?
So I would like to congratulate your very interesting two cases. But for the second cases, I have some comment that because the patient have the cardiac arrest, so you have to check your angiogram again. Yeah. Without any reason, you have to check angiogram. I think that you can check for two reasons. You should check that any artery perforation is still there or not. And what about the thrombus? After you have very slow flow after the case. So I think the patient is quite lucky. He overcome the cardiac arrest. But I think I have chance when we check the coronary angiogram again after the cardiac arrest.
Thank you very much. For the, it's very my concern after the case to redo the CAG for the third time, and I also check for the echo at the table very strictly and do the AKG and monitor the patient. But I predict it's it's not change much, so that is why I denied to do the test one. Thank you very much.
That reading the IVUS is not so easy. So they say a good IVUS is easy to read, but a bad IVUS, a bad quality IVUS, is very difficult to read. And looking at whether you're in false or true lumen with volcano IVUS is actually very difficult. But it's also very easy if you've done it a lot. If you have a false lumen in a distal LAD, okay, the false lumen is going to be the bigger lumen. If your IVUS is in a true lumen, it's going to be in a smaller lumen. Because in a distal vessel, where there's a true and a false lumen, the false lumen is always much bigger than the true lumen. Your IVUS in the distal is in the big lumen, which brings me to the conclusion that you stented into false lumen, and that's why you cannot get better flow.
I wanted to say that also, but I had some concern to make this comment, but it's true. That distally you're in the true lumen, but I think honestly at a certain point on the IVUS front you see the fully compressed small false lumen, but only on a short part, and then you're still again in the true lumen. That's also why the septals are missing in the middle part of the LAD, and then they're coming back distally. And potentially the patient reacted to amiodarone. That's a good point. It's a miracle that he survived. It's quite an interesting case. So finally, the final outcome is good, and it's a kind of ADR, involuntary ADR, something like that. You agree?
So yeah, absolutely. I think it's very difficult, the occasional IVUS. Actually, up until about 5 or 6 years ago, when we were still using volcano IVUS, I was often trapped by this same problem because it just haven't got the resolution for you to see clearly that false lumen. So you don't know. So it's, when we wrote about investment procedure, we always say stenting is a bad thing. So sometimes if you're not sure, it's best just to balloon and leave it and let a little bit of flow go down between the true and false rather than to put stents in. So that is probably one useful thing to do.
I have another choice. I think that we can use the thrombus catheter to selectively to infuse in the adenosine or the nitroglycerin. But I think that you can infuse via the thrombus catheter to selectively to the distal part of the LAD. I think it's better than you infuse everything in the left main, like your case. Yeah.
Actually, I use the microcatheter. I use dual lumen catheter, microcatheter to inject the adenosine and nitrate. And thank you for your comment. And this part, I really concerned about the true or false lumen because it's very important. And I saw like it's the spiralization at the mid LAD too. So that is why I cannot leave it and I find out it's true or false. And I combine many signals, like I go to the side branch with the Y and the distal part. After wiring, I see some brand at the contrast to the distal side branch. So that is why I decide to deploy the stent. Thank you.
So any question or comment from audiences? Oh, this section. Maybe we come back to the third case of PCI in young AMI with multivessel thrombosis. Is there any question?
About the third case, I think Dr. Tuan has left the building. But I'm still puzzled. I do not think that the thrombus is, it's just too much of thrombus. Are we dealing with some hematological issue, antiphospholipid syndrome and things like that? Even in your OCT, the disease was not so obvious to me. And I think actually once you see TIMI3 flow, just medical treatment would have actually, dispersed the thrombus. You could have treated it, So I think there's something else going on. You don't see that much of thrombus everywhere. And then trying to chasing the tail, trying to suck out, it just doesn't work that way. It will come back. It's just too much of thrombus. And you can see his vessels, and it's so young. His vessels are so big, so healthy. And I think there's something else going on. Just that's my opinion. Thanks.
Okay, thank you. After the PCI procedures, we check the some antiphospholipid, protein C, protein S. It's all negative. So
the issue is when you have thrombosis and so on, they can after the event, sometimes it's not easy to diagnose. You can even ask the hematological side and so on. But just too much of thrombus everywhere, and the vessels look pretty healthy actually.
Mm-hmm. Yeah.
I'm the same idea. I think that the K from the Chien, I think these are the hyper anticoagulation stage. You have to find out what is the cancer associated. Make the patient very high hyper anticoagulation state. So you check the shadows. You suck all the thrombus around the body. You cannot do that. But I think that on the OCT, I also think so that the coronary is quite look healthy. So I think that your coronary rupture is just after you post dilatation go 3.5 mm balloon for a long time. So I think that we deploy the stent on that case quite early.
Thank you.
Thank you very much for the chair, panel, and all the presenter. We have 5 excellent presentations. We see how we can manage the hemodynamic compromise during PCI and rotablation by MCS from the presentation from Dr. Chui. And also Dr. Tech give us excellent and very educational management on the trap filter wire. And Dr. Wu give us lecture whole tips and tricks on how to prevent complication in rotablation. And Dr. Jen saw a very strange thrombus case everywhere. Left main LAD, sweat, peripheral vessel, and also cerebral. And finally, Dr. Wu bring us one interesting diagnosis is OSA-related coronary spasm, and another is controversial no refill or spasm or dissection, which I think difficult to make a final conclusion. But all these 5 cases will give us lots of inspiration, and I hope everyone enjoyed this section. And thanks again. Yeah.